Hello, everybody. Welcome to the first session of the day, I believe, for this Friday at SCCT. I am Blake Richards from Elucid, and we're excited to present to you Advancing Precision Cardiovascular Disease Pathways with Histology-Based Plaque Quantitation. So if you have not already, please go ahead and download or open the SCCT app. We'll have two great presentations by Dr. Mark Rabbat and Dr. Matt Budoff, but we'll have a live Q&A after the session. So if you open up this session in your app and you're able to avoid any Microsoft glitches from the outage last night, you can enter in questions and we'll be fielding them afterwards. If you are having any trouble or you just want to do so live, there's a microphone right here. Please feel free to come up and ask questions directly. So I'll kick this off by introducing Dr. Mark Rabbat. He is a professor of medicine and radiology, as well as the director of the cardiac CT, as well as the structural heart disease interventional imaging director in the Division of Cardiology at Loyola University Medical Center. He is also the advocacy chair for the advocacy committee of SCCT, where we had some exciting news very recently. So without further ado, I'll turn it over to Dr. Rabbat.
Thank you so much, Blake. It's a pleasure to be here with all of you. This morning, I'll be discussing when to utilize FFRCT and quantitative coronary plaque analysis in guiding our patients' care. So I'd like to begin by discussing data from the PRECISE trial, which is the first global prospective randomized controlled trial comparing the diagnostic and treatment pathways for stable chest pain. So over 2,100 patients were randomized, a little bit over 1,000 to traditional testing. The testing strategy was selected by the site clinician. So patients could undergo any sort of functional stress test, whether it be a stress ECG, nuclear stress test, stress echo, or even straight to Cath. That was at the discretion of the provider, and subsequent care and testing was made by the site clinician, and guideline directed medical therapy was recommended to all. Now, a little bit over 1,000 patients were also randomized to the precision pathway, and what I liked about this clinical trial is that you were deemed low risk based off of the PROMIS risk stratification. You deferred testing altogether. Now, if you're intermediate or high risk, then you underwent coronary CTA, and if it was indicated based off of the assessment of the coronary CTA, FFRCT was performed. And again, all subsequent care and testing was made by the site clinician. Now, the primary endpoint was the composite of MACE, death, non-fatal MI, and Cath without obstructive coronary artery disease. And you can see here that the precision pathway was superior to traditional testing at 1 year. And indeed, there was no difference in safety, but a significant improvement in overall efficacy for those patients that underwent the precision pathway. Now, this data was presented as a late-breaking clinical trial at the American Heart Association meeting and was recently published in JAMA Cardiology. So how does this pathway impact the Cath lab? So this is a representative example of a patient, as noted with this red arrow here, with an intermediate LAD non-calcified lesion. Based off of the anatomy alone, not sure if that's flow limiting or not, or functionally significant. So this patient underwent FFRCT, and you can see that there's a large delta gradient across that left anterior descending lesion, with the lesion-specific FFRCT value of 0.68, rendering that hemodynamically significant and warrants further intervention. The bottom left image is the invasive coronary angiogram that corroborates the CTA findings. And then the bottom right image is the post-PCI result with the resolution of the patient's symptoms. Now, I've had many patients over the years with similar anatomic narrowing, as you can see in the upper left image, but after assessment with FFRCT, those were deemed negative and can safely defer invasive coronary angiography. So with more widespread adoption of this pathway, what we're seeing is less invasive coronary angiography alone and more appropriate revascularization in the Cath lab, because we're picking up a lot of disease that we've been missing with standard of care pathways. I'm sure many of us in this room have seen patients with false negative stress tests, Because CT is such a sensitive modality, we pick up a lot of those lesions and we're appropriately revascularizing them. So I'd like to dive in a little bit deeper on the care pathway and journey in 100 patients undergoing traditional testing versus the precision pathway. So let's start with traditional testing. So of those 100 patients who would undergo usual care, if you will, 18 would undergo invasive coronary angiography, and only 4 of those 18 would receive revascularization with percutaneous intervention, and 2 with bypass. So 12 of those 18 patients actually undergo an invasive procedure and are found to have no obstructive disease, nor do they receive revascularization. Now let's contrast that with the precision pathway. So same 100 patients, 14 would undergo invasive coronary angiography, so 4 less than traditional testing. But as you can see here, there's 8 patients that undergo percutaneous intervention, so 4 more appropriate revascularization. Similar number of bypass patients, so only 4 patients are found to have no obstructive disease, nor receive revascularization. So this pathway leads to more high value and clinically indicated interventions in the right patients. And as you can see here, there's 78% more likelihood of identifying patients in need of revascularization and 3 times fewer unnecessary invasive coronary angiograms. Now this also translates into an increase in cath lab revenue and efficiency with this pathway. So you can see here that the invasive coronary angiography revenue with traditional testing is a little bit over $54,000, with PCI a little bit over $49,000, and you can see CABG at $104,000. In the precision pathway, the invasive coronary angiography revenue is lower. However, you can see that there's a significantly higher PCI revenue. So when looking at it in totality, this results in a 20% increase in total cath lab revenue and a 58% increase per cath lab case. Now we're moving beyond using information from the CT and FFRCT to act as a gatekeeper, if you will, to the cath lab, or to use the information to guide appropriate revascularization, whether it be with percutaneous intervention or bypass. But now we're able to look for changes over time with our interventions in pharmacotherapy, for example. So this was a patient that I've been following. You can see at baseline, there are a lot of pins here. All of these pins represent stenoses that are at least 30% diameter reduction. And you can see that there was a borderline functionally significant lesion in the left anterior descending artery here, and a borderline functionally significant lesion in the circumflex artery. Now, this patient at baseline had well-controlled LDL. I mean, the LDL was, I believe, less than 50 on a statin. Sugars were well-controlled. He was not obese. Was not smoking. The only change that we made from baseline to follow-up was the addition of a medicinal therapy, as noted here, called icosapent ethyl for his residual hypertriglyceridemia. And then at follow-up, at about a year, we were talking in clinic, and he said, "Hey, doc, can we take another look and see what's going on with my coronaries?" And I said, "Sure." So we did. And sure enough, at follow-up, at around 1 year, you can see that there appears to be an improvement in intracoronary physiology as assessed by FFRCT. And then we started to see this signal a little bit more in our clinical practice. And actually, Dr. Budoff and I, we actually collaborated on this and decided to formally study this using data from the EVAPORATE trial. And this is data from the EVAPORATE FFRCT study that we recently published in EHA Cardiovascular Imaging. And you can see that in those patients who received drug compared to placebo, as early as 9 months, we actually saw improvement in intracoronary physiology, again assessed by FFRCT, which was sustained at 18 months. So this is quite exciting data because this is the first study to demonstrate drug effect using this technology. And I think it really paves the way for future clinical trials in pharma to consider utilizing the data from both the CT and FFRCT to assess drug efficacy. Now we can do something very similar with information from plaque. This study was published in Circ Cardiovascular Imaging using Elucid software. And essentially what you can see in patients who had psoriasis, those that received biologic therapy actually had improvement in lipid-rich necrotic core compared to those that did not receive biologic therapy. And this early stage diagnosis was identified at under 9 months. post-intervention. So we can now quantify changes in atherosclerotic plaque, composition, and arterial measures for both use in clinical trials as well as patient care. So coronary plaque matters, and this is one of the seminal papers that studied that concept, published in JACC. So the investigators in this clinical trial studied over 10,000 coronary segments, followed them for 27 months, and they assessed for two different adverse plaque characteristics, whether the patient had evidence of positive remodeling or low attenuated plaque with less than 30 Hounsfield units. And you can see here that if a patient had both positive remodeling and low attenuated plaque, they had a greater than 22% risk of developing downstream acute coronary syndrome. Now, importantly, all events occurred in patients with stenoses that were less than 70% diameter reduced. So this really underscores the fact that there's a lot more to the story than diameter stenosis alone in identifying at-risk patients and lesions. And now we have AI-derived quantitative plaque analysis. And we can identify the plaque, we can characterize this plaque, we can quantify the burden of the plaque. We can look at total coronary plaque morphology, the burden of disease, vessel remodeling, as well as plaque stability and individual patient risk. And these are some clinical trials published in Lancet, JACC imaging, and EHJ imaging. In the Lancet paper, you can appreciate that those individuals who have more total plaque volume have significantly higher risk of downstream cardiac event rates in the JACC paper, and that was actually statistically significantly higher than those who have obstructive coronary artery disease. In the JACC imaging paper, even after adjusting for sex, comorbidities, as well as obstructive disease, total plaque burden, calcified plaque burden, non-calcified plaque burden, as well as low attenuated plaque burden, all provided prognostication in predicting downstream cardiac event rates. And in the EHJ imaging paper, you can appreciate that those with higher total plaque volume, again, had worse overall cardiac outcomes. Now, we can assess plaque progression and patient follow-up with coronary CTA and measure this progression and potentially changes in plaque type over time in response to medication. So in this study, those patients who received statin therapy had less progression of their non-calcified plaque. They actually had some regression of their non-calcified plaque. And what's interesting is that phenotype of plaque appears to convert to more of a calcified nature that's considered more stable and less at risk and vulnerable. So that brings us to the Emerald 2 trial. We actually just published this study this year, looking at standard CTA analysis versus AI quantitative coronary plaque and hemodynamic analyses. So in trying to predict individual lesions in patients that are at risk for downstream acute coronary syndrome. So we took patients who had an event and prior coronary CTA and tried to look at these features with standard assessment on CAD-RADS criteria, as well as adverse plaque characteristics, such as positive remodeling, low attenuated plaque, napkin ring sign, and spotty calcification, and compared that with these AI-generated quantitative coronary plaque and hemodynamic analyses. So looking at various metrics of plaque, such as total plaque volume, total non-calcified plaque volume, low attenuated plaque volume, burden of disease, as well as the length of the lesions. Those are some of the plaque features. We also looked at hemodynamic adverse features, so such as the delta FFRCT, so the FFR just proximal to the lesion compared to just distal to the lesion, which appears to be quite prognostic indeed in predicting downstream event rates. Looking at adverse hemodynamic characteristics such as axial plaque stress, wall shear stress, as well as the percent myocardium at risk. And interestingly, what we were able to demonstrate in the derivation cohort, you can appreciate that for CAD-RADS and high-risk plaque, the area under the curve was 0.76. And after incorporating these AI-derived quantitative coronary plaque and hemodynamic analysis metrics, you can see that there was a statistically significant increase in the area under the curve at 0.86. And then when looking at the validation cohort, we saw a similar signal of statistically significant improvement in downstream ACS prediction. So you can see that the AUC was 0.76 again, increasing to 0.84 after incorporating these AI-generated metrics. Now this is data from the ADVANCE DK trial. The ADVANCE study was a global registry of patients who had atherosclerosis on their CT, who underwent FFRCT when indicated and followed over time. So what you can appreciate here is that those individuals who have atherosclerosis but negative FFRCTs and the lowest quartile of atherosclerotic plaque burden actually had a very low event rate. Now, when you have lesions that are negative by FFRCT but significant plaque burden, the event rate seems to go up. And when you have lesions that are positive by FFRCT but lower plaque burden, slightly higher event rate. But the highest events were in those individuals who had both lesions that were positive by FFRCT as well as significant total plaque burden. Now, I also wanted to highlight that there appears to be temporal differences in outcomes in these patients. So what I mean by that is those individuals that have lesions that are positive by FFRCT appear to have events and an uptick in events earlier on in their cascade. And those that have larger total plaque burden tend to appreciate events later on. So the way I think about this in our clinical practice, for example, is if I have a patient with a positive FFRCT, that provides me with more actionable information, what I'm going to do for that patient now in the near term, whether we're going to cath that patient, whether we're going to revascularize that patient. Whereas significant plaque burden may guide us on what we're going to do for that patient long-term, their long-term risk. So this is a flow chart on how we can consider utilizing both of these analyses in our clinical practice. So we have a patient with suspected coronary artery disease. We perform a CTA. It's interpreted. Now, if there's no plaque or stenosis seen on their CT or their CAD-GRADS is 0, then we can confidently tell our patients they don't have obstructive coronary artery disease. This is well described in the literature. The negative predictive value of this modality is quite robust. And importantly, the warranty period is quite strong, meaning our patients are not having events. Our annualized event rates in the setting of a negative CTA is very low. So that's quite reassuring, and then primary prevention could be undertaken. Now, for those patients that are identified to have plaque on their CTA, then we can consider plaque analysis in those individuals. And if you have a diameter stenosis anywhere in the range of 40 to 90% stenosis, this was the range that was published in the American College of Cardiology, American Heart Association chest pain guidelines, then you can consider further evaluation for hemodynamic significance, such as FFRCT. And this is one of my last slides. This is my last slide. Wouldn't you rather go to the cath lab empowered with all of this information? So we talked about how we can very accurately assess stenosis on CTA right now. I think one of the next big frontiers, not just in cardiac CT, but in cardiology for that matter, is going to be AI plaque analysis. We can assess delta changes across lesions of FFR, which is quite prognostic, as determined in the EMERALD study as well that I just presented. As well as other metrics such as vascular volume to myocardial mass on these scans. We can very precisely quantify myocardial mass, vascular volume, and we're learning a lot about coronary physiology, coronary artery disease with these metrics. We actually published data on this a few years ago now on gender differences between that metric. So for example, men have lower vascular volumes to myocardial mass compared to women. So what that translates into is that smaller changes in diameter stenosis in a male will have a greater impact on one's intracoronary physiology compared to a woman. So I think once we're able to incorporate and extract all of the wealth of data on these CTs in a clinically meaningful way, I think it's really going to get us closer to identifying vulnerability at both the patient level as well as the lesion level. So I'll stop there, and I'll turn it over to Dr. Budoff. Thank you.
All right. Thank you so much, Dr. Rabbat. Now I'd like to introduce someone who probably doesn't need an introduction, but Dr. Matt Budoff. He is a prolific cardiac imager past president of SCCT, and a founding member of SCCT. He is currently the professor of cardiology at UCLA. He's the endowed chair of preventative cardiology at the Lundquist Institute at Harbor UCLA Medical Center.
So thank you, and thanks for getting up early on the first day of the meeting. We'll make sure we get you out of here for the opening session. Just want to take you through a little bit of what we've been doing with plaque composition, both in clinical trials and now in clinical practice. But I think the concept is that with good histology, and you already heard a lot from Mark about the potential of using these type of AI-assisted tools to get more information. But as we learn more about these plaque imaging features, I think we can do better than just saying Hounsfield units below a certain threshold is low attenuation plaque. And I wanted to kind of focus in a little bit on a technique that's been used to look at what they call lipid-rich necrotic core, which has been validated against histopathology. So they took carotid arteries from carotid endarterectomies and used that low attenuation plaque as from pathology to correlate to CT. We can't do that in the coronaries very readily, but it's a way of getting down to this exact metric as compared to low attenuation plaque, which is just largely just a Hounsfield unit threshold, which of course, as you know, based on acquisition parameters and scanners, could change quite a bit as we use a different KV in different applications. So this is a FDA cleared histologically validated plaque analysis, looking at CTA angiography, and again, it was correlated against true histology to give us an answer as far as what is low attenuation plaque, or what is now what we would think about as a lipid-rich necrotic core. So we use this in the EVAPORATE trial. Mark already mentioned it briefly, but this was a trial that we did with CT angiography, looking at icosapent ethyl or Vascepa, and randomized patients to either placebo or icosapent ethyl with statin in the background, and followed them for 18 months. As part of that analysis, we had the plaque characterization done by Elucid, looking at lipid-rich necrotic core, looking at fibrous cap thickness, looking at intraplaque hemorrhage, and assessing all of these metrics in a blinded fashion. So we sent them blinded images, blinded scans, and they did their analysis. And what we were able to show is that we found an improvement in lipid-rich necrotic core with this therapy, which correlated with our overall finding of less total plaque, non-calcified plaque, and other plaque features that got improved with icosapent ethyl in our core lab analysis. So it correlated nicely, but they were also able to see things that really focus on the vulnerable plaque. Things like not only decreased lipid-rich necrotic core, but things like fibrous cap thickness and things like wall volume improved. So a thicker fibrous cap and less lipid-rich necrotic core were some of the key findings, and all of these were statistically significant. And keep in mind, this was a relatively small analysis. They only had 60 images, 60 paired scans to look at from baseline to follow-up, so 30 in each group, and still were able to show a very nice distribution where we had improvement with icosapent ethyl and progression with statin monotherapy. Here we saw, again, just some of the images, lipid-rich necrotic core. We get a plaque volume, we get a minimal cap thickness or fibrous cap thickness and wall thickness, and we get interplaque hemorrhage. And all of those things were improved with icosapent ethyl as a group as compared to placebo. So we saw a stabilization effect, which was very robust and correlates very nicely with the Reduce-It trial by Deepak Bhatt and others, where they showed that icosapent ethyl reduces cardiovascular events by 25% in a parallel study that was being done simultaneously. So we know that icosapent ethyl reduces events. We know that it reduces the need for angiography, for stents or bypass surgery by 11 months. And at 9 months, we're able to show plaque stabilization. So really a nice correlation of kind of a histopathology, CT imaging, anatomy mechanistic study correlating with a nice outcome study over the similar timelines. We saw changes in plaque composition, overall improvement in plaque with these different patients. So there's been some newer data as well, looking at histology for CT, looking at plaque, looking at histological plaque correlation. They have a new platform now, and a better performing platform now, and you can see the results on the right for calcification area with an R squared of 0.95, lipid-rich necrotic core of 0.88, and a matrix non-calcified plaque, if you will, of 0.86. So very high correlations. And here you can see looking at correlations compared to a Hounsfield only based thresholding, much better performance. So you can see on the right the Elucid performance here. And again, the type is way too small to read any of the statistics up there. I apologize, but performed very, very well with total plaque volume with a Pearson correlation of 0.86, and again, correlation for calcified plaque of 0.91 and non-calcified plaque volume of 0.74. And a 0.54 correlation for lipid-rich necrotic core. So again, looking at better metrics with lipid-rich necrotic core than we've seen with low attenuation plaque from other measures. Here's just a look at the images going up from left to right. The original CT image, you can now see the low attenuation plaque volume in red, quantified using just Hounsfield-based software. And you can see it lights up pretty brightly. So it looks like there's a lot of low attenuation plaque just based on a Hounsfield unit threshold. But if you look actually at this lipid-rich necrotic core using this new software, you can see that there's very little lipid-rich necrotic core. So I think getting better validation will lead us to a better answer and not just say any Hounsfield unit below X, minus 30, whatever number you're going to use in your threshold to define low attenuation plaque. There's a lot of different thresholds that have been thrown out there, but now we can see that this patient doesn't have diffuse low attenuation plaque in that middle image, but actually has very little low attenuation plaque on the right. And I think better correlations and better results are going to lead us to a better answer as far as how vulnerable that patient is and how aggressive we need to be with that patient. So plaque is important, as Dr. Rabbat just reported. Plaque quantification matters. Accurate plaque quantification is going to obviously matter. And low attenuation plaque, at least the current way that we're doing it, is not the same as this metric that's been histologically validated called lipid-rich necrotic core now. So I think we're going to be more specific, more accurate, and hopefully leading us down a road of better stratification for our patients so we know who to put on all of these therapies, right? I mean, in the old days, Dr. Rumberger's here and one of the very early pioneers, and we were out there saying, oh, you should use coronary calcium. If you have a high score, you should put them on, you can intensify therapy. Well, I already have my patient on a statin and an aspirin. What else can I do? And we're like, yeah, you probably don't, that person probably doesn't need a calcium score, but if they're not on a statin and an aspirin, maybe get a calcium score and you can decide who needs it. Now, if you tell me you have a patient on everything, that's almost impossible. They can't swallow all those pills and take all those shots of things that have been validated to be better than statin therapy or add to statin therapy, right? So we have lipid-lowering agents, we have triglyceride-lowering agents, we have anti-inflammatories, we have diabetes drugs that have all shown incremental benefit, but we don't know who to apply them to and how aggressive to be, right? We have rivaroxaban, we have anti-colchicine, anti-inflammatories. We have all different therapies that we could potentially put people on, and if we had accurate assessment of risk and more accurate assessment of who's really has vulnerable plaques, I think we can start to better differentiate who needs more aggressive therapy. So I think it's going to really help us move this forward. So again, we have this concept where we can get plaque IQ technology, we can get this low attenuation plaque and this histologically validated plaque quantification. We can add, as Dr. Rabbat showed, the very important information we get from FFRCT and have a combination of good histological correlated plaque along with who has flow-limiting lesions and really, really stratify risk and get them on many very appropriate patient-specific intensive medical therapy. We can really individualize or personalize treatment with better accurate assessment. So just again, this is just a comparison of looking at atherosclerotic plaque characteristics, looking at ischemia or looking at FFRCT, and you can see as we go from left to right, here we can see if they just had a stenosis, moving over to stenosis plus body calcification, if we add in low attenuation plaque, as we add in other features of different plaque characteristics that would be associated with high-risk patients, you can see the improvement in predicting events. So as we add in these metrics, we're going to get better risk prediction, as Dr. Rabbat showed us, and again, a better correlation. And this is a couple other studies that have demonstrated improvement. This is the Credence trial. I was involved in this study looking at atherosclerotic plaque character features, looking at vessel-specific FFR, and improving correlations. We know that endothelial dysfunction is associated with increased intravascular lipid-rich plaque. This is a study that was done, a small study, but a study that was done looking at patients with mild stenosis. But you can see that if they had epicardial endothelial dysfunction on the left, they had a much higher cardiovascular or chance of having pathological findings. So we can look at multiple different ways of looking at this, and we know that endothelial dysfunction is associated with pathogenesis of early atherosclerosis, and we can see more plaque features in these patients. So we really can correlate a lot with clinical outcomes. So just to finish up, so we have some time for Q&A, this is looking at a FFRCT derived from a routine CT. And again, we can now apply these metrics as a number of companies are doing now, looking at FFRCT to give us these answers as to which lesions that may look bad or may not look so bad are physiologically significant. And anybody who's used FFRCT from any vendor recognizes that our visual assessment of stenosis is often not enough, that we see a lot more once we know if it's physiologically significant, and I think it helps guide. We use it a lot. I have one of my patients today, he's getting us, going to the Cath lab this morning in California, who had a very, very moderate lesion. I thought it was only moderate, but FFRCT showed it to be quite significant. So I think these are the type of things where we can help derive who needs to go for stenting, who needs to go for bypass surgery, who needs to go beyond medical therapy, and really guide treatment quite a bit. Just as we think about this in an overall way, we have this comprehensive analysis of coronary disease. We have compositional indices, calcification, non-calcified plaque, lipid-rich necrotic core. We have structural indices, stenosis, plaque burden, the remodeling, and now we also have function, FFRCT, and we can put all of these together into one package and hopefully get a very, very comprehensive answer for our patients that translates not only to better patient care, but better communication with both our patients, who will understand that those lesions that look bad are not so bad based on these metrics, or that plaque burden that sounds high, they have a high calcium score, is not so bad as far as acute risk goes, and we can treat them more moderately, or that lesion that doesn't look so bad is actually very significant, and you have a lot of lipid-rich necrotic core, and you have flow limitations, and we really need to do something more about that patient. So I think we can really derive that. There is a new cardiac CT registry called Preview. You can see run by Martone and Carlo, who are going to be looking at a histology-based cardiac CT registry for prognostication of events. And they're going to collect 10,000 patients worldwide. So if you're interested, you can see the contact here. And I think Carol is here somewhere, sitting over there. So feel free to talk to Carol about getting involved in this study as well. So I'll stop at this point. Thank you guys for getting up early, and we'll open it up for some Q&A.
All right. Thank you, Dr. Budoff, and thank you, Dr. Rabbat, as well. So everyone remember, you can go to your app to ask questions directly, or there is a microphone right here. Or if you have a loud enough voice, please feel free to just raise your hand and call them out. I'll start off with a comment, but I'll turn it into a question. So one person says, I'm usually very torn when I face a patient with high-risk ASCVD score and no calcium on their scan. On the statin-fearing patients, whenever this is available, hopefully I can use this to educate or convince them more. Have you seen plaque analysis visualization or FFRCT visualization help convince patients to improve their medication adherence?
Yeah, I mean, absolutely. And, I still have a lot of faith in a calcium score of 0 for patients over the age of 50. I think if they have a score of 0, their short-term risk is low, to be honest, in most cases, especially if they're asymptomatic. But for those younger patients, for those patients with FH, for those patients with diabetes, where you may not be so comfortable saying you don't need to be on treatment, I do CT angiography in those patients if you can get it approved, or if they have money to pay out of pocket. Asymptomatic CT angio is not covered as well as symptomatic CT angio by payers. But I found a great improvement in compliance once you show them that they have some plaque, and if they have non-calcified plaque and you can show it to them in their Prox LAD, and maybe it has some histological features that make it even more vulnerable, I think that's an easy sell to the patient to start therapy.
Yeah, I would agree with that. These risk calculators are excellent when, looking at an epidemiologic perspective, but the individual patient that's sitting in front of you in the room wants to know, their risk or individual risk, and that doesn't always correlate. So having information from the CT scan and the understanding of plaque, the plaque features, the morphology, the composition, the burden, is quite helpful, and it's very tangible for our patients that we take care of. I mean, when they see their atherosclerosis, they're more inclined to adhere to their lifestyle modifications, take their preventative therapeutics, et cetera. So, for example, in my practice, I actually sit down with the patient and I'll show them their images of their, coronaries, and they understand that, and then they're more adherent to all of those things we were just talking about. So yeah, I find it quite helpful.
Fantastic. All right, the next one we have is, how does image quality and scan parameters impact Hounsfield unit-based plaque analysis versus how does it impact histology-based plaque analysis?
Yeah, so go ahead, Mark, when you start.
Yeah, so it's all about image quality. So, and we actually train an imaging fellow at our institution as well, and that's one of the first things that we talk about, how, if you don't have high quality images, unfortunately it's challenging sometimes to derive these subtle changes. We're looking at coronary arteries that are yay big, 1 to 5 millimeters in diameter. So if there's cardiac motion, artifact, it can be quite challenging. So that's very important. And there appears to be a clear relationship between how we acquire these images, what their heart rate is prior to acquisition, and diagnostic image quality. So we pay particular attention to that because otherwise some of these metrics may be quite challenging to derive.
And I think it's obviously the radiologists say GIGO or TITO, garbage in, garbage out, or trash in, trash out. If you don't have good images, the best of us can't read and get a good answer especially for cardiac CT, as Mark described, as you all know, with these small arteries that are moving, and try to get a real answer for them. As far as KV goes, though, it's very important to keep in mind as you change your acquisition parameters, the density of all the tissues on CT will change. And I'm a bit concerned that we're not paying enough attention to that when we do longitudinal assessment of patients. Our techs If they've had a scan before, they have to scan in the same parameters. I don't care about MA as much if they want to give them a little more MA because they've gained some weight or something, but they need to give the same KV. And if they don't have that fixed, then we have a problem with tracking progression over time. If you want to do quantitative plaque assessment, the histologically derived metrics that I described here take that into account. So I think that we have a step up over some of the other metrics that are AI companies that are not yet incorporating KV into their algorithms. And I think that'll change because I think they'll realize that it just doesn't make sense if you have a patient scanned at 120 or 130 KV at baseline and then 100 KV in follow-up, because now we're trying to get our doses down in our lab more, and all of a sudden everything looks brighter and denser. And if you just go by density and you change the KV, density of everything on that scan is going to go up. So you're going to have a shift in plaque, and plaque features more calcification and more different densities for all of your plaque. So I think that's the most important thing right now, is pay attention to the KV.
Perfect. We have one question that I can answer quickly, which is which scanning vendors does the software work for? There's no limitation. It works for all vendors. It's been tested across the board there. We do have a question is, do you see this plaque and FFRCT information being used downstream in the Cath lab? Are the interventionalists actually looking at this to guide their procedures? Yeah,
I think Europe's way ahead of us on this. I was on a panel at TCT, the interventional symposium, last year, and they had a whole session on cardiac CT in the Cath lab, and they have these incredible images. I was jealous, but they had beautiful, beautiful images of cardiac CT, and they were guiding interventional approaches in the Cath lab, much like we've been doing for more than a decade, guiding the electrophysiologists in the Cath lab for things like atrial fibrillation. We can do the same with interventional cardiology, and I think more and more interventionalists are using the data, not only using the data from a perspective of where the arteries are or where the bends in the arteries are or what angle to use for TAVR or something like that, but looking at the FFRCT and the vulnerable plaque characteristic changes to decide on where to intervene. So I think that's a natural approach, and we need to continue to educate our interventional cardiologists as well, not only the born-again interventionalists that might be here that consider themselves more imaging or prevention guys and women, but we need to get to the interventional cardiologists and educate them on the value of CT. And when they go to the Cath lab with a CT, it's not just to say this is an appropriate patient, but here are the lesions that you should pay attention to.
Yeah, absolutely. And you know, we can also derive fluoroscopic projections, from the CT, and that's quite helpful. So, I've started to incorporate that in some CT reports. If you see a, proximal LAD lesion, certain cranial caudal, RAO view, you can also incorporate that. I know that some centers also project the images in next to the fluoro. So when they're injecting, in the Cath lab suite, they'll have the information side by side. And I think we'll also get to the point, there is some data published on the R&D level that we can perhaps even perform virtual stents and predict outcome of revascularization even prior to entering the Cath lab. So I think we'll eventually get to that point as well.
And it's interesting, there's a symposium this mid-morning on this topic, but 3 out of the 4 talks are not talking about using it for EP or structural heart disease, where we're already using CT a lot. 3 out of the 4 of the talks that they have scheduled are how I help plan interventional procedures and PCI and those type of things. So I think there's, we're definitely moving very rapidly towards this unity of having these advanced plaque features for our interventionalists that can then be parlayed into an appropriate intervention.
Yeah, and I always like to say that, cardiac CT is really the bridge between the invasive and non-invasive worlds, where we come together and we use information in a meaningful way to guide not only identification and risk of patients, but also patients who benefit from revascularization as well.
Perfect. We had one, I'll just call it logistical question about the registry. Just please email carol.holt, H-O-L-T, @elucid.com, or go find Carol after this right here. The next question is, how do you see photon counting CT impacting the usage of these softwares?
Yeah, so I think obviously our next great horizon will be better image quality, and photon counting CT looks to be, we kind of moved through dual energy, and now we're on our next horizon here. But photon counting CT, I think, is the real deal, and I think will really change our metrics, because the image quality is everything. And as you have less noise and better image quality, we're not only going to be able to see stenoses more accurately, but we're going to be able to quantify plaque more accurately. We're going to be able to quantify plaque type, and FFRCT will all improve with better image quality. So I don't think there's any question that that'll be our next frontier.
Yeah, we don't have a photon counting CT at our institution, but from what I've read and heard is that there may be a real opportunity, for example, in stented patients, there may be an opportunity there, which would be great to improve the, identification of the lumen and the boundaries of these prior revasc patients.
And we'll do just one more here, unless this one. Okay, we'll do two more then. One, we'll go to the mic first.
So we're now coming out with a number of companies or software to evaluate plaque and FFRCT. And as users, it becomes hard to compare them and try to decide, hey, which one is better. So as a society and just a group, how is there, especially like in plaque quantification, you're going to compare literature, you kind of want an idea how the different ones compare to each other. It's kind of important, especially at least ballpark, to hope that, you read one article and they're similar. What is the way, is there a role somehow to try to compare them and to try to, for the SCCT or somebody to try to help us, same with FFRCT, help us decide how these are? How do you see that going?
Yeah, no, I think that would be ideal, right? To have an external, independent analysis and have somebody, make the metrics on all three, or now 4, 5, 6, whatever number they're going to be of these companies that are going to be able to do these measures and see which one performs best. The problem we have right now is correlation. Do you correlate it to IVUS? Do you correlate it to invasive FFR? Do you correlate it to histopathology? But I think you can look at the individual papers. So low attenuation plaque is noisy. If you look at other metrics, I know there was a study done where the correlation was 0.28 in one of the registries, and that's not very good. Here we had much higher correlation with this. So I think if you're looking at individuals and you want to look at different metrics, you could look across papers, but as you mentioned, they're done differently with different patient populations and different readers, and often they try to optimize their results by only selecting the best of the images. So we definitely need that. I think the answer will be trials like Scott-Hart 2, Promise, where we have images that are already collected that are independent. They can be analyzed by different companies, and then we can get we can see if the answers are similar or not. So I think we'll be able to do that. We just need to fund that type of work.
But it seems like you can do that it's easier to do that with outcome. But it's harder with plaque because the gold standard for quantity is harder, right?
That's true, but if one predicts outcomes better,
right,
you probably have your right answer.
But
That's our
I'm
gold
just saying,
standard in cardiology, at least, is to try to figure out who's going to have an event and who to treat more aggressively. But you're right. And histological gold standard, we could try to do that as well, but you would need to find an IVUS-derived population of patients that have CT and then apply it to the different algorithms. You can't use any one, and I can't go to Clearly or HeartFlow and say, I want to do this for Elucid or vice versa. They're going to say no.
Well, that's why the question is it a role for the SCCT?
Yeah, and I think that would be great for the SCCT to think about that, is to be the independent monitor of this. But then picking one company or saying one is better than another puts them in a funny position as well. The AHA and ACC have stayed away from that from drugs. They didn't want to say that Eliquis is better than Xarelto or vice versa. So I think it's a little bit challenging. I need to wrap up soon. Yeah.
Great question. Yeah, we'll do last question to wrap up. We'll do a short answer for this.
1
So,
minute.
It says,
Session starts at 7:55.
so plaque analysis, FFRCT, we're coming from stenosis. What's the next frontier? What's the next measurement that you think is going to be most important here, if there is one?
After stenosis, I think we have now two. We have FFRCT and we have now AI quantified plaque analysis, and I think both of those are going to be used, and they should be used in conjunction with each other. So I think those are the simple answer, and Mark showed that most elegantly, I think, with the advanced registry.
Yeah, I agree. I think they're incremental and complementary to each other, and they provide us different information. But I also think that the forces across the lesion are also going to add value and trying to focus more on how these plaque and composition of plaque impacts, wall shear stress, plaque, axial plaque forces as well. So I think all of that is going to be important.
Perfect. Well, thank you, Doctors Budoff and Rabbat, and appreciate everybody, and we'll see you at the symposium.